The lamina propria, that's that connective tissue, and then the villi, because when we get to the duodenum, it's all about absorption now. Okay, small intestine's all about absorption. So we're going to see changes in the villi as we move through the small intestine. So they look one way in the duodenum, and then in the jejunum slide, they look a different bit. Okay? Then we move into the large intestine, and there are a bunch of goblet cells in it that we'll look at. And I'll put all this out. Then there's the liver slide, the pancreas slide. So those will be the slides along with the lung slide and that trachea slide that we looked at last time, right? So that we got several slides on this one. Okay? Okay, so let's look at our model right quick. Let me take you through things right quick. And this model is not in here right now. Somebody borrowed my model, so I have to go probably drive to Corinth and get it. So I will have it here for Thursday. So instead of going in the nose, the nares, and down around the nasal concha, and this way, we're going in with food this way, right? Right off the bat, we've got lips that help with that, okay? Keep the food in the mouth, so you close your mouth when you eat, that way the food doesn't fall back out, right? In there are also teeth that do the mechanical crushing of the food that we eat, okay? So we got to take advantage of the jaws, their ability to go up and down like an alligator does. They also can go side to side a little bit, so we can do the movement, right? And then you can also go front to back, okay? And there was a guy at our deer camp that's what he did the whole. You see his jaw doing this. Like, doesn't look right. Okay, so anyway, 3 different movements there. We've got the tongue to keep it in place. Here's the hard palate. Right, the upper part of the oral cavity, the hard palate, and then it turns into the soft palate back here, where there's no more bone. Remember that palatine bone that we talked about? Okay, and then hanging down is the uvula. We've talked about it before, a little punching bag in the back of the throat, that when we swallow, it swings up and blocks off things going into the nose. And I've seen people, you know, put spaghetti in their nose and pull it out their mouth and do right? Because they have the ability to get past that uvula, okay? So, I don't do that though, that's gross. Okay, but when we think about the digestive system, we should be dealing with the oropharynx, right? And the laryngopharynx. But really the nasopharynx is kind of excluded unless we're throwing up or something and food's coming out your nose, right? And usually that uvula keeps it from doing that. The uvula is supposed to close off when we throw up. It's supposed to come out your mouth. Although I had a picture in my thing. I still need to find it. It's this dude, he's throwing up and you can see 2 big streams coming out both nostrils as he's throwing up. And it made a girl sick in my class, so I took it out one time. So. But it's a good picture. All right. So then when we swallow, what's the little flapper here? To close off, epiglottis, to close off the glottis, and that forces us back here into the esophagus, okay? So once you're past where the trachea and the esophagus start, now we're going to be into the esophagus, okay? Otherwise it's pharynx before that. This is a muscular tube down to the stomach, okay? Muscular tube. And the first part of it, really the portion that's in our neck, kind of this upper portion, this has skeletal muscle here, okay? And we have the ability to try to contract it on our own with our own big old noggin, right? We can kind of do and try to pull things up, okay? Also force things down when we're swallowing. But once it gets down into this area where we're past that, now it's all smooth muscle, okay? And the way the smooth muscle is going to set up, we'll see a picture of this. There's going to be a ring of smooth muscle. Okay? So there's smooth muscle bands that are going this way, they're running this way, and then there's smooth muscle bands that are running up and down. 2 different rings of them. So what I get to do is, if it's in this shape, they're going around, I get to do this. If they're going this way, I get to do this, right? So I do squeeze and pull, Squeeze and pull. Okay, squeeze it and pull it.
So what are you squeezing and pulling?
The food that you just swallowed. Okay,
Why are you squeezing and pulling?
to get it to my stomach, otherwise it's gonna be stuck right here.
Isn't that called
So when you
peristalsis?
squeeze, what does it mean to squeeze?
Contract muscle
Where?
in the esophagus.
And what do you
Right here
put
that we're
to
talking about.
in the esophagus too?
So we're bringing it all the way down into the stomach. And then from then on, that peristalsis that Alex said, that is the term for moving the food through the digestive system.
This might be a dumb demonstration, but when you say that, I think of like that magic school bus where it's like squeezing it down like an icing bag, like where you like.
Yep, and that's what they're trying to kind of show us.
Okay.
Okay, so, from then on, it's all to be smooth muscle, and smooth muscle is involuntary, right? So we don't have to think about it. Okay? Lots of the drugs that we take, especially those that are designed as painkillers or anesthesias, those families of drugs will work on smooth muscle. Okay? And it slows down the progress of smooth muscle. So we have to turn this back on a lot of time. Okay? Like how many times have you awoke in the middle of the night and had to go poop? Not that many times, right? It's not if you're sick or diarrhea or something like that, yeah, that's different. But a normal night, I have to get up and go urinate, okay? Pretty often, once a night maybe, sometimes not at all, but, right? But I don't ever have to get up and poop right in the middle of, so pretty much when we go to bed, we kind of slow all that down with smooth muscle because it's involuntary, right? Okay. So if you take these drugs and it slows it down, okay, do we have to wait till somebody poops before they leave the hospital? And if you had a surgery or something like that, they want to see you poop, okay? Because the risk is the patient could be constipated, go home,
Impacted.
and become impacted, have to come back. And the worst case of that, my friend that's the doctor, she was at Anchorage doing her residency, and the lady had had a baby and had to have an episiotomy. So there was stitches and it was pretty, and she had not pooped in 13 days. So that was, she said that they had to take turns wearing masks, wearing the big shield, right? And getting in there with little forceps and breaking the poop off to try to get to, because it was so dry. So don't do that, okay? We need to poop. Pooping's good.
No
All
color.
right, so smooth muscle from here all the way to here now, okay? So, the esophagus. Not much going on here in the esophagus. It is a tube that goes from really the mouth to the stomach. There are lots of organisms that, like fish, don't have an esophagus. We have to have this because what's here and here?
The lung.
The lungs, right? So we had to get it past all that to get it down into the abdominal cavity, not the thoracic cavity. Don't really have much going on thoracic cavity this way. So there is a sphincter here called the cardiac sphincter. Cardiac because of the heart's right here, okay? And that's what keeps the food in the stomach. It keeps it from going this way, okay? As I got older, I developed some gastric reflux when I would go to sleep at night. I was creating too much acid in my stomach, so when I laid down, that acid could creep into my esophagus and burn, give me heartburn, that kind of stuff, right? So the doctor said, jack up the bed a little bit so that it's a little bit higher up, like a little ramp, and that would help that. My wife didn't like it, and I didn't either, because as you slept, you gradually sank toward the bottom of the bed. You'd wake up and you'd be all curled up down at the bottom, like, where my pillows are way back there, okay? So then I got on some medication, that kind of stuff. Everything's better now, okay? Then this is the stomach. This is probably the thing that we think about as one of the most important parts of the digestive system. Guys, this is pretty much just a big holding tank, okay? We do some digestion here, okay? But we do very little absorption, okay? So this is not what we think, because what can we do? What we can do now is put a band around this and lose a whole bunch of this stomach, right? Or go in and have a lot of your stomach cut out. right? For weight loss and things like that. So, we got lots of things going on here. The parts of the stomach around the esophagus is called the cardia. So this is the cardia of the stomach. Where it humps upward, this is called the fundus. The main part is called the body. Where it narrows is called the pylorus. And then there's another sphincter here that says once you're done in the stomach, you get moved into the small intestine through this sphincter, this valve, and that's called the pyloric sphincter. Okay? From the pyloric sphincter, we move into the first part of the small intestine. There are three parts that we're going to know. The duodenum is the first part. Second part is the jejunum. Third part is the ileum. Okay? And what a lot of models try to do is give us different colors so that, this first part down to maybe about here is duodenum, and then jejunum is up here, and then the ileum is here. Okay? It's pretty much a guess where it's going to be for us. Okay? First part duodenum, middle part jejunum. Yes.
So does that little valve keep acid from leaking into the small intestine?
Well, it's going to get in there anyway. But the good thing is that's where we're going to neutralize it. Okay? So there's a little tube, there's a little sphincter right here that you can see that has a green line coming up, which is coming from the gallbladder. Okay, so that's your common bile duct leading in here. And then this white fishbone looking duct comes from your pancreas, and they come in together through the, okay, and I like this, hepato for the liver and the gallbladder, pancreatic sphincter, hepatopancreatic sphincter. Okay, so both of those together squirt their juices in here. Now this one, the first part of the small intestine, the duodenum, they call it the mixing bowl. This is where we're going to mix a bunch of enzymes. We're going to neutralize the acid that we were talking about. Okay, and we're getting it ready for absorption. Not a ton of absorption happens here. Okay? But now, once we move it from the duodenum into the jejunum and the ileum, it's all about absorption. Okay? So, a few things can get absorbed in the stomach. One of those being alcohol. Okay? Remember, alcohol is lipid soluble, so it can go right across. So people that drink on an empty stomach, are they going to get more intoxicated?
Yes.
Yes, because that alcohol will absorb into the food stuff as well, right? It's inside the stomach. And it'll make the travel along, and that'll make it not be absorbed as readily. Okay? So it is true, you should always eat before you go drinking. Times are tough right now, though. If the goal is to get drunk, though, don't eat, don't drink then, right? I'm just kidding. I'm just kidding. You should drink something for them, okay? So, we had a doctor of neurobiology at UNT, and he was talking to his class about the effects of alcohol on their urinary system, right? And he sent them all to the bars to get to drink and notice and look at their urine. He got in trouble, y'all. You can't be sending them to the bar to go get drunk. So it was kind of funny. So once we get through the small intestine and we've done all the absorption, there is this connection here from the small intestine, which the bottom of it is called the ileum. There is this valve here into this pouch-like structure sticking off the end of our large intestine. That's called the cecum. So the ileum into the cecum through the ileocecal valve. That's this valve here. Okay? Now that you're in the large intestine, we're done with absorption. It's all about compaction and getting rid of the waste. Okay? Yeah, we'll do a little bit of absorption of vitamins and things like that, but nothing really like we were doing in the small intestine. Okay? So you travel up. This is called the ascending colon. It makes a 90-degree turn here. They call this the right colic flexure, or because the liver's here, the hepatic flexure. It travels across the transverse colon. We got another 90-degree turn. Here's the spleen. They call this one the splenic flexure, or the left colic flexure. goes down the descending colon, makes this little jog here where it makes this little S shape. That's called the sigmoid colon. Sphincter here into the rectum. The rectum is what has the stretch receptors on it that when waste gets moved into the rectum, it goes, oh, got a load, it's time to unload. And we get the urge to defecate then. Okay? And it's not one of those things that we have to do immediately, right? Okay, but we got to make a plan. If you're driving down the road and you're, I just passed, a Buc-ee's, that'd have been a good place to stop. They got nice bathrooms. It's going to be about 30, I can make it 30 minutes, right? Okay, so it's that kind of deal. Or because you think that next one up the road, that's a trashy bathroom. I stopped in there before.
So what is an ileostomy?
Well, that means they're going into your ileum. It's a camera in your ileum.
Okay.
Like a colonoscopy, they're taking a camera, and that's one of the issues with these 90-degree turns. They got to get a camera, turn and go this way, then turn and go this way, then turn and go this way all the way down. Sometimes they can't do it. You're not set up where it can make, your intestines are not set up in the right position. Okay, so.
What about the ileostomy like bags? Like why would somebody?
So that means we're gonna bypass the colon itself.
Oh.
They're probably colon cancer, that kind of thing is what I would imagine. Okay. Okay, so that's a pretty good, here's your liver, okay? And then we've got the right side and the left side, right lobe, left lobe, and then by underneath it, there's the caudate and the quadrate lobe that we can see on our liver model. This little green guy here, this is your gallbladder, okay? And it empties, okay, through the common bile duct down into here. And there's good pictures of that there as well. This shows you a stomach that's laying there, the outside part of the stomach. And here's that transverse colon going across that has, see these little bulges that you can see? Okay, those are called the haustra.
May I ask a question?
Sure.
You sure that say something is the stomach? So is it in the stomach you have the intestines and all that? So the stomach is something different?
Yeah, stomach is its own organ. So the stomach is before the intestines. Yep. So each one of these are the haustra of the large intestine. I'm trying to think if there's anything. Oh, here's the appendix sticking off the cecum. Now, animals with a big cecum, okay, a big pouch-like cecum, they are plant eaters, okay? And inside the cecum, we have enzymes that would digest more of those sugar starches that we don't break down as well, okay? Y'all have all eaten corn before and went to the restroom and went, there's corn in my poop, right? There's corn in my poop. That's because we don't break it down very well. We didn't do a good job of breaking down that cellulose, okay? That's a polysaccharide. We don't break that sugar down very well. But there's organisms that do real well with that. Okay, they break it down completely, like deer and cattle and things like that. They love to eat corn. Pigs.
So if you don't break down the corn, does it mean you didn't get converted to sugar in the system?
Exactly. Exactly. We didn't get to utilize everything that was there. Okay, and as y'all probably know, there are organisms that will eat other organisms' poop. Because there's still valuable nutrients that weren't absorbed. Okay, so we see that a lot. So that cecum in a vegetarian is huge. Okay, in organisms that don't eat meat. Okay, they're huge.
Spell the cecum.
Okay, the cecum.
Spell it.
C-A-E-C-U-M. Okay, sometimes they'll leave out the A in front of the E and just be the C-E-C-U-M.
Oh, cecum, C-U-C-M, C-U-M.
So, it's this big pouch. Well, what's happened over time with humans is what anthropologists think is that our cecum, we went from being more of an herbivore to less of an herbivore now and more of a meat eater. Okay? What's happened to our cecum is it's shriveled up. And that little appendix is what's left over of the shriveled up cecum. And that is full of lymphoidal tissue because that lymphoidal tissue that's associated with the digestive system we call gut-associated lymphoidal tissue, GALT, right? There's tons of it here. So could we get a bunch of lymphocytes fighting an infection here in the appendix?
Yes.
And what will we call an infection being fought in the appendix? Appendicitis, right? And could it indeed rupture?
Yes.
And if it did, would that create an opening that our large intestine is now dumping stuff, waste material, into our abdominal cavity?
Yes.
Yes. And could that be lethal?
Yes.
That's why there are
Because of
so,
the pathogen?
Hmm?
Is it because of the pathogen?
yes, and everything else that, the waste material, the toxins that are in there, all that's going to continue to be dealt with organisms. There's organisms that live in our large intestines, right? Y'all got them? Everybody checked? I talk to mine usually in the morning, tell them good morning, right? Y'all have heard of probiotics, right? That's things that you're supposedly taking orally that'll make their way down and they will help set up good gut bacteria, right? And I asked my doctor friend about those one time. I was like, how do you feel about the probiotics? She goes, not so big on them. You put it in there, where does it have to go first? It's got to go to the stomach and get hit with hydrochloric acid and that kind of stuff. And that kills most everything, right? It's like, I hadn't even thought about that. And then what's left has to go through the small, it's got to go all through this long. She said it'd be a lot better if they stuck it up the other end. And she was being serious. And y'all, that's what they do. They do fecal transplants on people now.
What?
Yes. Gut flora. So,
So is that the big debate between when people do those colonics?
oh, that's a big one, yeah,
Because are you doing more damage than?
absolutely.
Okay.
Excuse me, with people with C. diff, do they also do the fecal transplant?
Ooh, I wouldn't know, I don't know about that.
Because I was wondering.
My neighbors had it. I don't think that was a treatment that they did, but it was,
Only because, like,
yeah,
it's rough.
yeah. Yes,
I've heard some people refer to the gut as like your second brain.
and there's a lot of nervous intervention there, a lot of nerves that are through there. Timing is critical for certain things to happen. And we'll learn all about these local hormones that once you go from here to here, we got to turn this off, turn this on, right? And then once it progresses through this turned on part, now you got to turn you off, turn you on. Well, if you eat something, now we got to turn this part back on. And I mean, it's switching back and forth a lot.
Is it possible to strip the gut of all the good bacteria, or at least most of it?
Well, and that's one of the things that we think antibiotics will do at some point. There are lots, if you've ever taken antibiotics, which when I got my tooth pulled, did I tell you that story? Okay, so on Tuesday, it was earlier. Actually, I think it was before class had even let out. I started getting a little bit of a toothache before spring break. And I was like, it hurts right there on my jaw. So I let it go. Wasn't really killing me, and figured it'll fix itself. Then I developed a big old knot on the side of my jaw. And I said, I've got an infection in my jaw. So I made an appointment, went to see my dentist, and talked to and she's been there for 10 years, and I've been going to him for over 10 years, so I've known her the whole time she's worked there. And she's real sweet, and she said, hey Doug, what's going on? I said, I got a problem. She said, is it mad? And I said, yeah, it's very angry right now. So she said, well, let me see it. So I just pulled, and she goes, oh my God. So it had a big knot on it that came out where my wife could see it on the side of my jaw without just to see me if I was looking at her. She's like, yeah, I can see how swollen it is right now. So I go in, they give me antibiotic to get it started because we learned about this. Why would dentists give you antibiotics? Where's it gonna go from here in the venous system? Where does it go?
It goes to the heart.
It goes to the heart, right? And people die from that, right? And that's that whole valvular heart disease and things like that.
So they gave you what?
The other
Anti
thing,
what?
what?
What did the doctor give you?
Antibiotics,
Okay.
okay? So, gave me antibiotics to control this, because they're going to pull my tooth out is what he decided at that point. So he gave me rounds of antibiotics, big old amoxicillin too, y'all. Well, what that does is kill, it's pretty much designed to kill everything, right? So when the amoxicillin hits my large intestine, it starts killing my gut bacteria, which gives you the diarrheas, right? So I've been having the diarrheas, I'm still on it, still got the diarrheas, okay? But then I go in on Thursday to get it pulled, and he gives me the shots in my gums and that kind of stuff, and I'm gonna deaden it up real good, and I'm like, yeah. So he get, and he's giving me these shots, and he goes, okay, let's see, can you feel this? I'm like, yes. And he goes, really? I gave you enough shots that it shouldn't. I said, I know what I felt. So he goes, all right, well, let's give it a little bit more time. He gave me a couple more shots. He gave it a little bit more time. So he comes back in and he goes, okay, I'm going to put the extractor. And what the extractor does is it grabs a hold of your tooth really hard, right? And sometimes it will actually cause, if you've had dental work done to that tooth, like a root canal or something, it'll squeeze so hard it'll just break the tooth, okay? So that's how hard it squeezes. So he starts squeezing on my tooth like this, and I can feel how hard it's squeezing my tooth. It hurts. And he goes, he said, is it the pressure or is it pain? And I said, both. And he's like, he pulls that out. He goes, I know what's happened. That infection has created a pH imbalance in the tooth. And the Novocaine's not working now because there's too much. It's too acidic. He said, you think you can? And I'm like, yeah, we got to get it done. Let's go. I was ready to fight somebody by the end of this day, y'all. Oh my God. So they got it. And when they got it, all the pus came out of that, into my mouth. I could. So I'm still on great big amoxicillin. They're about this big for about, I think it's about 5 more days. And I don't have this tooth, okay? And I'll show y'all which one in lab or in lecture when we get to that part. But it's the one right where your tongue sits like this and then your mouth does this, right in front. It's the one that kind of helps with your tongue keeping it in line. So my tongue keeps flopping over here in this hole and I keep biting it, okay? And I've bit it so many times now, it's very sore from being bitten, okay? So I'm not moving my tongue very much anymore. So when I talk, I'm just kind of leaving it right there in the middle and just wiggling a little bit.
So when they do a wisdom teeth surgery on your jawline, sometimes they have to go in and like get impacted teeth out. What is the dry socket like? Is that an infection or?
So, like you can't use a straw. One of the things about that straw causes you sucking, okay, will do the same thing in the socket. And it creates irritation inside that socket, nerve, so it's really nerve irritation because that nerve's still alive in there. So, all right. So, let me show y'all some stuff. We've got intestines like this. We start with remember, here is the trachea right here. What's this tube behind the trachea? The esophagus, right? So the esophagus is going to be this tube behind it. Here's the esophagus coming down here, and then into the stomach. We'll put the stomach like this, and the stomach sits where the big part is at the front of the stomach. So this is the beginning, this is the end. okay, beginning and end. So that makes this the cardiac sphincter. That makes this the fundus, the body, and then where it narrows down into the pylorus, down to the pyloric sphincter, okay? And they say the greater curvature of the stomach and the lesser curvature of the stomach, okay? When you open it up, it's full of ridges, okay? This is gonna help move the fluids along. We call these the gastric rugae, okay? Gastric rugae, okay? There's also palatal rugae in the roof of your mouth where it's nice and bumpy, okay? And we'll see it really well in the cat when we look at that. But that's the stomach, so there's several things to know on the stomach. Then from the stomach, we go into the small intestine. So you can see that this is gonna be the duodenum. Here's the pancreas beside it. Here's the little green going in, and where the green and the white meet, that would be where that hepatopancreatic sphincter is. In the duodenum, there is just a duodenum model somewheres. Okay, this pancreas duodenum. All this would be small intestine. So the upper part, let's call that the jejunum, the lower part, the ileum, okay? Then there's a little opening right here where the ileum comes into the large intestine. That would be the ileocecal valve. Everything below that is cecum. So where my finger is down here is the cecum. And if we turn it over, we see the little tail. What's the little tail down here? The appendix, right? And anytime they're doing surgery and they happen to get close enough to your appendix to reach over and get it, a lot of times they'll just reach over and snip your appendix and put a suture in. That way it doesn't cause you any problems, right? So they took mine when I had a inguinal hernia, okay? So they just went, snipped mine while they were there. We don't have very good at the very bottom, but here is the liver, okay? And it shows you this line right here that separates the left from the right, okay? And then the caudate and quadrate lobe, and then it shows you this green thing underneath. This is the gallbladder with the different ducts that feed it, okay? And we'll talk about that. And you can see we have to know hepatic ducts and common bile and cystic duct, okay, where it actually goes into the gallbladder. And there's pictures of that on the coloring portion that I gave you, okay? And I would recommend doing as much as you can to label this colored one, the one that you're going to be coloring, okay? So that's what we're going to do today. We did get a bunch of new pencils, coloring pencils and that kind of stuff. They're down here. If you want to do the coloring here in class, you can. But please return them back to their designated pencil keeper. Nice, right? 24. These spare no expense for you guys. Okay? And we have them in the pen case. No one's labeled them yet, but my anticipation is it will be labeled at some point. Because that's what you do. Everything has a label in this building. Have y'all noticed? Even door stops. Some door stops say this is the door stop for room such and such. Like we're going to steal somebody's door stop, right? But all of these are labeled. All of this. They went crazy labeling stuff. They put a label on the label maker. It says label maker. Okay?
Do the left and right sides of the liver do the same thing?
Yeah. And liver is one that we have learned is very regenerative. So you can take a big section of the liver out and let it just regrow, as long as it's in pretty good shape. If it's very alcoholic liver or something like that.
Is that what they do with liver transplants? Like they can take part of it and
They can take part of a liver, yeah, and hook it up. Okay, yes, ma'am.
Okay, so I'm wondering about like, how like whenever you drip too fast and then the water ends up in the wrong, like, the wrong side and then it like causes like your like, what's that part called?
Diaphragm?
The diaphragm to like, and then it
Give you the
just-
hiccups and that kind of
that
stuff.
happens to me all the time, like, can you explain?
Yeah, you're not doing it right. The hiccups are more of a nervous, involuntary nervous response to something like that. And when we get something in the, either when things are moving too slowly in the esophagus, okay, that can trigger that hiccup to start to happen because it's almost like you're trying to get it up. Okay? Fluid does it if it gets into the trachea the same way because we're trying to create pressure to force that out of the trachea. So that's really all that's happening. Okay. So next week, y'all get all this down and we'll be going over this in lecture. Okay? Next week we'll do the CAT and we'll do the slides. And then we'll be ready for the test the next week.
It's gonna be
In
the
lab.
Thursday, right? Next Thursday?
Not next week, but the next week.
Okay.
Are we gonna have the cat in the lab exam?
Yeah.
If we have a heart?
Yeah.
So what do we do this Monday?
Learn all the parts. Do the coloring, identify the parts. Yes?